We are honored to have our grand round speaker today, Dr. Stanley Perlman. Dr. Perlman is a professor of microbiology and immunology and pediatrics at University of Iowa. Dr. Perlman is a world-renowned physician who has done extensive work in SARS, MERS, and also now coronavirus. Dr. Perlman published a very nice article in New England Journal of Medicine earlier this year and has been instrumental in development of policies for COVID-19. We are honored to have Dr. Perlman as the speaker today. And thank you so much, Dr. Perlman, for doing this for us.
Okay, thank you for inviting me. So what I'm going to do today is try to describe some of the things that we know about COVID-19 and also put it into the context of what we know about two previous severe pathogenic human coronaviruses, the one that caused the severe acute respiratory syndrome in 2002-4, SARS-CoV, and also the MERS-CoV, the Middle East respiratory syndrome, which is causing an ongoing epidemic, or actually outbreak, in the Middle East, and mostly confined to Saudi Arabia. So I have no conflicts of interest, and the goals of this talk will be to talk about human zoonotic and potential pandemic coronaviruses. I'm going to try to cover several questions that are often asked, fake facts and real facts, and talk a little bit about SARS-CoV-2 infection, which causes COVID-19, which is the disease, and information about the replication strategy, antiviral strategies, and vaccines, and there'll be time for questions. So some of the questions that periodically come up are, what about pediatric disease? Do children get less disease than adults? Influenza causes more illness and death, so why are we worrying about COVID-19? This may not be true anymore. The mortality rate is low. What is the big deal? Can the virus spread asymptomatically? How is it transmitted? Why is it so hard to control? And is immunity to other coronaviruses protective, irrelevant, and detrimental? You can see that many of these topics have actually been discussed and raised even over the last few days. Other questions or facts that are frequently asked questions, they say the coronavirus, there's only one. Was the cruise ship quarantine a good idea? That's an easy one. The answer is no. Why did SARS disappear, and is this virus pandemic? How long will a vaccine take? Do we have any drugs to treat this? Should I avoid taking NSAIDs like ibuprofen? Should I stop my antihypertensive drugs? So to start off with coronaviruses, coronaviruses have been around a long time, and they've jumped from other species to humans several times. 229E and NL63, which are two coronaviruses that caused a common cold, diverged 1,000 years ago, and before that had already transmitted from species to other species to infect humans. We know that 229E circulates in camels in the Middle East. So whether it originates there or not, we don't know, but since MERS also circulates in camels, there's a possibility that this is just reflecting the close relationship between camels and people there. OC43 probably went from cows to humans about 100 years ago, and cows have also infected many other kinds of bovids around the world, including elk and similar species. And then, of course, SARS crossed species about 16 years ago, or actually now it's 18 years ago, and MERS 6 years ago, and that should really say 8 years ago. So the endemic coronaviruses, the one that caused the cold, are 229E and OC43, which we knew about in the 1960s, and HKU1 and NL63, which became obvious or became identified in 2004, right after the SARS epidemic, when people started becoming more interested in coronaviruses and started hunting around for other viruses that could infect humans. And we know that these coronaviruses cause up to 15 to 30% of human colds. And one of the things about them is there's no durable immunity. There's frequent cycles of reinfection. And this is an important point as we think about SARS-CoV-2 vaccines. How durable will immunity be? These viruses cause mostly upper respiratory tract infection. And one of them, NL63, uses the exact same receptor that SARS-CoV-2 does. So an interesting question is, why does NL63 remain only in the upper airway? It may have to do with its temperature sensitivity, and this is probably the most likely explanation. They all cause lower respiratory tract infections in immunocompromised patients. and the severity and contributions to the general population are really not so well known. But we do know there's outbreaks, particularly in nursing homes, of some of these like OC43 or 229E. And no vaccines or antivirals are licensed for any of these. So emerging coronaviruses, we have two that we think about a lot. One is the SARS coronavirus, which occurred in 2002 to 4. There was 8,000 cases worldwide with a 10% mortality, and it was in 32 countries for 3 months, in 3 months. And this is a curious disease because it really started in China, much like SARS-CoV-2, and it started in the wet markets in China where live animals are bought for food. In 2002, I think the markets were different than they are now. There were more exotic animals in the markets. Since the SARS epidemic, the Chinese government has clamped down on the number of exotic animals that are in the market. But in 2002, what we think happens is that there were bats in the market, and at the same time there were these other animals, civet cats and raccoon dogs that look like this. These are animals that I didn't know anything about till 2003. The Himalayan palm civet cat, which is not really a cat, and the raccoon dog, which is not a dog. And these were the intermediaries. We think that the virus started in bats, and then it transferred to these civet cats and raccoon dogs. And they weren't really well adapted for either the civet cats, raccoon dogs, or humans. But the virus, we could see the virus evolve with time in all of these species to adapt to humans. And probably in the market, what was going on is virus was transferring from the bats to, or the whatever animal had it, the civet cats, the raccoon dogs, or the bats, to people. And most of the time, people just developed an immune response that really mostly either had subclinical disease or very mild disease, again, reminiscent of what's going on now with SARS-CoV-2, yet occasionally it caused really severe disease. And we think that the outbreak in China probably occurred when virus crossed species to infect handlers who infected other people in China. And this probably happened several times, and that explains the Chinese epidemic. But what happened in the rest of the world is that, and I'll go over this in a minute, is that the physician taking care of an animal handler went to Hong Kong for a wedding, and I'll get to that in a minute. So MERS is a disease first described in 2012, and I'm not going to spend much time on this, but it's a curious disease. It's a disease that's really a disease of camels, and so far in total there's been 2,500 cases with about a 35% mortality, and it's in 27 countries. We see roughly about 2 cases a week now. And this is undoubtedly initially a bat virus that has been in camels for a long time, and I'll mention that in a little bit as well. And one thing I should point out is that in SARS, the total of 8,000 cases was equivalent to about 12 to 16 hours of new HIV cases in the world at that time. So even though this was a major deal for the world, in total human burden, it was actually much less than HIV. And finally, we come to the third major coronavirus, which is SARS-CoV-2. This slide is way out of date. It talks about 75,000 cases. And of course, that's off by a factor of about 10. And the mortality is more than 2%, we think. So the severe acute respiratory syndrome in 2002 to 4, I already mentioned that it had 8,500 cases. And again, fear was the major factor in concerning this disease. And that's one of the things, of course, with SARS-CoV-2, though, of course, SARS-CoV-2 has crossed over from being just something that one could fear to something that's clearly a major tragedy. So I think I mentioned this already, that the SARS originated in bat population and across many times in the wet market. But what I was saying before about what happened to give the worldwide epidemic is that the virus infected animal handler, who then went to see his physician, and his physician became quite ill. And the physician, when he was ill, instead of going home to be cared for by his family, he decided he needed to go to Hong Kong to be taken care of, to be at his nephew's wedding. And when he was at his nephew's wedding, he became very, very ill, and happened to be on the same floor with people from visitors from the countries listed on this slide: Canada, Ireland, all these other countries. And so he, by the nature of his illness, he actually aerosolized the virus and infected all the people on his floor, or many of the people on his floor. They went home to their own countries, and that helped start the epidemic. And a lot of these are not direct links, because the Canadian one was via somebody who traveled from Guangzhou or Hong Kong, I forget which, back to Canada. So it wasn't all from the initial hotel, but the episode at the hotel infected a lot of people who then went back to their own countries. Middle East respiratory syndrome, I mentioned a little bit about this already. Some points that are worth noting is that the immune response is often transitory, and I'll show this in a minute. This makes epidemiology studies difficult. It makes one wonder if there's going to be increased likelihood of reinfection. This is, again, a theme that's coming up as we think about SARS-CoV-2 and COVID-19. And in the Middle East respiratory syndrome, like SARS, was actually a disease that was really had a large impact on hospitals. We didn't know enough about human-to-human transmission, and there were a lot of healthcare workers who became ill, both from this disease and initially from SARS. Now we know more about SARS-CoV-2, so people are taking all the necessary precautions to prevent spread within hospitals. But as we can see in places like Italy, hospitals are so overwhelmed that healthcare workers are still at risk from becoming infected. And MERS had the most severe cases were in patients with comorbidities, including diabetes, chronic lung disease, renal failure, and immunocompromised state. Again, a theme which we're hearing again with COVID-19. And so what do we know about protective immune responses in coronavirus infections? In non-SARS, non-MERS human respiratory coronavirus infection, protection is transient. Is this because there's waning antibody? We have a little evidence for this. Vaccines against coronavirus infections in domestic and companion animals provide imperfect protection. In the case of chicken coronavirus, infectious bronchitis virus, vaccines the live attenuated vaccines were prepared that worked, but then they were excreted into the environment and they ended up recombining so that now more virulent vaccine-derived IBV was in the chicken community, so this was a problem. The best vaccine that ever rose for coronaviruses was actually rose naturally, so nature designed this for us. This was a virus called porcine respiratory virus. There's a disease called transmissible gastroenteritis virus, which is a severe disease of swine. And this virus caused great economic losses throughout the world. And people tried to develop vaccines for it. They weren't terribly effective. But then sometime about 20 or 30 years ago, a new virus arose, porcine respiratory virus. And this virus was almost the same as TGEV, but it was deleted in the part of the virus that's important for binding to the gut. So the virus could still grow in pigs, but it no longer caused severe disease. It acted like a great vaccine, and TGEV was basically eliminated. So it's hard finding any in the world now. And this virus, this live attenuated vaccine, induced antibody and T cell responses, which is why it was so effective. And most vaccine efforts now focus on developing antibody responses, but in fact, T cell responses are probably equally important in developing a vaccine that's efficient. And certainly that's what the TGEV story tells us. And then, of course, there's a big issue now, a big discussion now of using passively delivered antibodies to either protect against the onset of disease or even as therapeutic as early on in the disease course. So this is an illustration from MERS showing that how rapidly virus antibodies disappeared. So with patients with severe pneumonia, you could still detect antibody 18 months later. This is a study that was done by my collaborator, Abir Al-Shukari. But if you had mild pneumonia, that's lines 3, 4, and 5, you started with good antibody titer, but it wasn't detected 18 months later. And even by 10 months, it had mostly declined. So this is a concern both for SARS-CoV-2 immunity and also for vaccines for SARS-CoV-2. This is an illustration of what happens in patients with MERS-CoV. You can see that these are two patients in black here, are in an ICU, and they have antibody titers that are sky high. I believe both of these patients ended up succumbing to the infection. This one may have survived, I can't remember. But you can see that 2 years later, these are not the same patients. You can see this is the level of antibodies. So even though in the ICU they have sky-high antibody titers, and these are neutralizing titers, by 2 years later there's almost no titers left. So virus antibody wanes very quickly. So let's go on to what we know about COVID-19. This was, of course, caused by SARS-CoV-2. As of yesterday, there were 780,000 cases, not the smaller number I had on an earlier slide, and deaths are higher than the 2% I had on the earlier slide. It's 4.8%. But as has been discussed in many places, this number is really probably way overestimates the death rate, because we know that there are many, many people now who have subclinical or asymptomatic disease. And one of the characteristics of this pandemic so far is that testing has been not good, except in a few places. So we don't really know what the denominator is, how many people really are infected. And it may be that the percentage, the mortality, rather than be near to 5%, may be near to 0.5 to 1%. Still a lot of people who will die from the infection, but not as bad as 5%. These are the countries with infection now as of March 29th, which is 2 days ago. You can see the circle shows the size of the outbreak or an epidemic in each place. What's remarkable about this slide is that almost every country is involved, and the ones that aren't involved are either countries like Yemen, which are in the middle of a civil war, or other countries where testing probably has not been done very well. So this is certainly a pandemic, a worldwide disease. And in the US, we have cases in every state so far, with the biggest number of cases in the New York City region. So what do we know about this virus so far? Bats are the probable source, but we've never found a bat virus that's exactly the same as the SARS-CoV-2 virus. So the possibilities are that either that the virus, it is a bat virus, but the specific one hasn't been found yet, or what seems more likely is, just like with SARS, that the virus went from bats to some intermediate host, which then served as the host for human infection. But we don't know that intermediate host. For a while, there was an animal called the pangolin, which is harvested in China for medicinal purposes and food. It's basically extinct in China, but it's imported from places like Malaysia. And in October, well before this began, pangolins were being smuggled into China. They were intercepted by agents who deal with smugglers, and the pangolins were taken to a repository in Guangdong province to be resuscitated and put back in the wild. And while there, they noticed a lot of the pangolins were sick. And the pangolins were sick actually with the coronavirus that resembled SARS-CoV-2 very closely. Further examination showed that while parts of it were extremely close to SARS-CoV-2, parts of it were not. So we think that this was not the immediate precursor to SARS-CoV-2. But this is the kind of thing that could happen where an intermediate animal gets infected by a bat, and then that ends up in this market. These animals, if they were in the market in Wuhan, it was illegal, and then they were able to then spread to human hosts. The mode of transmission of this virus is predominantly droplet and contact. That's why the recommendation of staying 1 to 2 meters away from an infected person or from other people is actually a good way to prevent the infection. Aerosolization may occur occasionally. It certainly occurs in hospital during aerosol generating procedures, but it's not considered the major way that the virus is spread. And whether the virus is spread by fomate is a question. The incubation period of the virus is about 5 days, with a range of 2 to 14 days. And of course, we know now it's human-to-human transmission is sustained everywhere. And the period of communicability is considered to be 14 days. Whether this is correct is not clear. Virus products can be detected for longer after this, but whether these people are contagious or not is really not known. And the transmissibility is really going to depend on where you are. In hospital settings, it may be very different than in the community. So this is a variable that we have some idea about. The numbers 2 to 3, which means a single infected person will infect 2 to 3 others. But this is taking a huge range of R naughts or R zeros from people who don't transmit to others who transmit at high levels. Based on, as I mentioned already, based on other coronaviruses, as well as what we know about droplet spread, if you stay within 6 feet of a patient for a long period of time, you have a better chance of becoming infected than if you're more distant than 6 feet. And in fact, some people will say 3 feet or 1 meter is sufficient, but the official recommendations now are 6 feet or 2 meters. And you need to have direct contact with infectious secretions. And this contact, usually what happens is it gets on your hands, and then you put your hands to your face, and that's what actually causes the transmission. And SARS-CoV-2 has been detected in urine and stool, infectious virus that is, but the clinical significance is unknown at present. And routine environmental cleaning and disinfection is not only appropriate, but necessary. So this was the first case of an asymptomatic infection. And this was later retracted, but I'll spend a minute on this. This was a patient who was at a meeting in Germany, was supposed to be completely asymptomatic, went home, and then people in Germany became infected with the virus. Now, one thing that was noted on further inquiry is it turned out the patient, while she was in Germany, was actually sick, or she had some symptoms. So she really wasn't an asymptomatic carrier who then infected others. However, we now have more evidence that spread does occur from asymptomatic individuals. And there's two kinds of ways this could happen. It's really hard to sort this out. One is that it could occur during the very early prodromal phase when people are just becoming sick with the virus. And it could, in theory, also occur from asymptomatic individuals because virus is detected in the nasopharyngeal swabs of these people. In this case, a person would have to be very close to someone else because presumably the virus spreads during normal activities like just even talking. And since you're not coughing or sneezing, the virus is not going to be propagated long distances from the person who's infected. So this is still a work in progress, but it just points out that this idea of standing 1 to 2 or is officially recommended 2 meters away from other people should minimize the likelihood of infection. And that would certainly be true for infection from somebody who's asymptomatic because they're not sneezing or coughing. The incubation period, as I already said, was about 5 days with a range of 2 to 14 days. Whether this extends beyond this to a significant extent is still needs to be determined. And the case fatality rate, as I mentioned, was around 3 to 4% now, or even a little higher. But what this is going to turn out to be is unclear. Right, as when this was written, which was only 3 weeks ago, the global fatality rate was 3.5%. China was a little higher, and the rest of the world a little lower, but that's changing, as we know. So the age of confirmed patients in China in February was as follows. You can see that the percentage of children 0 to 9 years was very low. That was about 0.9%. The majority of cases were actually in patients who were between 30 and 60 years of age, and with a drop-off after that in terms of confirmed cases. But what we knew that was unfortunate is that the mortality rate doesn't follow this pattern at all. So in people who are over 80, the mortality rate in this study was 14.8%, and this has been confirmed since February 17th. In larger studies around the world, people who are over 80 have a mortality rate somewhere between 15 and 20%. So they are the ones who are really most susceptible. And even people who are 70 to 79 have a higher susceptibility than other populations. The young have a very low case fatality rate, ranging from 0.2% to 0.4%. This is something that when we talk to young people, they say, well, we're not going to get this infection. And in fact, this isn't true because 0.2% mortality still is higher than flu. And in addition, of course, young people can go home and infect their elderly parents or grandparents. So it's important that everybody respect this virus. And I think people are doing this more than they used to. In the US, we have similar numbers. And here just looking at the red boxed areas, the mortality rate for the greater than 85-year-old population in this study was 10 to 27%, and even for 75 to 84 was still about 4 to 10%. So this is definitely a disease of the elderly, and a lot of the elderly have comorbidities, so sorting all this out is a little difficult. I think the general idea, though, is that age is really a major factor here. So again, this is as of February, but these numbers are still valid. This is a measure of disease severity, and about 80% of people develop mild symptoms, and we can even add to that, there's a large population of asymptomatic people. The severe disease develops in about 12 to 15%, and about 5% are critically ill. And then there's a higher morbidity among those with higher fatality among those with comorbidities or no compared to those with no comorbidities. The clinical symptoms, I think we all have heard about. Fever is very important, and fever and cough are the main presenting signs. One of the challenges, though, is not everybody has a fever and not everyone has a cough, and they can still be COVID-19 positive, still have COVID-19 disease. So this has to be put into the equation of diagnosis. And as I mentioned, many people seem to be asymptomatic. And then you have the usual things, myalgia, fatigue, shortness of breath, and less commonly diarrhea or productive sputum. This is similar to what flu presents as, so it makes it hard to distinguish the two viral infections. And the thing about both COVID-19, SARS, and MERS is that patients tended to get worse during the second week of symptoms, and it may not be for the same reasons. With SARS and MERS, it was a time when virus was being cleared, and then you could see clinical disease occurring. In this case, it may be virus tracking from the upper respiratory tract to the lungs, but it may also be during the period when virus is being cleared. So this brings up the notion that a lot of this disease is really an immunopathological response to the virus. And 17 to 29% in these studies of hospitalized patients developed ARDS, and some fraction developed secondary bacterial infections as well. So there's a couple of things I'll discuss in the last few minutes before questions. So one is the need for antivirals against coronaviruses. And what we would like to have, knowing, well, we'll go back a step, we've had 3 bad coronavirus infections in the last 20 years. We know that bats have other coronaviruses circulating within them, which can infect human cells in animal models. So these viruses, in theory, are ready to cross over to human species, assuming they can adapt. We know that the antibodies don't neutralize future zoonotic coronavirus as well, because every coronavirus has a unique, or not completely unique, but a fairly unique region for binding to the host cell receptor. That's why the SARS coronavirus antibody has some efficacy against SARS-CoV-2, but it's not perfect. And vaccines would, unless they're carefully designed, would not have cross protection against all of these vaccines, all these viruses. So the ideal thing is to develop, and then vaccines take a long time to develop as well. So the ideal thing would be if we had a drug that could be given early to people who have the infection and really aborted the infection. And universal vaccines across all coronaviruses will be difficult. And we know that aged individuals who are the most susceptible to this infection develop immune responses to vaccine least well. So if you have an antiviral, it may solve a lot of these problems, assuming that it can be given early during infection and was widely available and hopefully oral and not toxic and not expensive. So this is a high bar to cross, but that would be the ideal thing. So as I mentioned, the goal would be to develop antiviral agents that are active against a lot of coronaviruses, and one that would have a high barrier to resistance so that once the virus mutated, it was no longer virulent. And we'd like to have an extended therapeutic window for prevention, amelioration, and treatment. And this is important because the drug that I think is most useful now is one called remdesivir, which I'll talk about in a minute. But this is a drug that we give in the hospital to patients who are often quite ill. It may be too late because by then the virus itself may be not the problem, it may be the host immune response to the virus. And again, we'd like to have oral administration because then you could give it to lots of people when they're just getting ill and prevent their becoming more seriously ill. Much like the way we give Tamiflu to people who have influenza. If you give Tamiflu very early, it works. If you waited 2 or 3 days, it may make a 7-day disease into a 6-day disease, but otherwise doesn't really help that much. So first I'll talk about antivirals. In fact, that's what I'm going to spend most of the time talking about. So as I mentioned, remdesivir is the most promising drug, I think, right now on the market. And what it does is it binds to the RNA-dependent RNA polymerase that's found in all RNA viruses. SARS-CoV structure shown on the left and dengue virus on the right. And they all have very similar structures and polio in the middle. And because these are similar, remdesivir has efficacy against several of them. Remdesivir was as I said, it works against the polymerase, was initially designed for Ebola. And we know from studies of coronaviruses that the resistance results in a loss of fitness and the virus is attenuated. Remdesivir was used in the Ebola epidemic. And while it was one of the four interventions being tested, it was actually not considered as good as some antibody combinations, so it was not pursued any longer. So even though it worked well in mice and non-human primates, it didn't work so well in people. And that's one of the reasons that remdesivir now is being studied all around the world in controlled trials, because we don't know from the data that we have so far that it'll actually help in people who have SARS-CoV-2. And again, I mentioned, I'll repeat it again, that's really important to give it give it in the early stages of infection. That's what we think from the animal studies, because viruses could be cleared without affecting the clinical outcome. So unfortunately right now, as I said already, it's being given later in the infection. So if it's given early, if you want to give it early, it's IV, it's expensive. Who do you give it to? And a biomarker would be useful, but we don't have one now. Certainly patients who have comorbidities or elderly would be first in the line to get the drug. We've also have two other approaches here that I'm going to not talk about monoclonal antibodies or convalescent syrup, but the other possibility which I like is the idea of host-directed therapy, modifying or blocking the disease course, because so much of this disease seems to be immunopathological, seems to be occurring as virus is cleared. And this was the idea in the original therapy during the SARS epidemic, because people were treated with a drug, ribavirin, and also with steroids. Ribavirin was supposed to clear the virus, and steroids were supposed to tone down the immune response. Unfortunately, ribavirin had no effect on the virus, so steroids basically acted alone. And what they ended up doing was diminishing the immune response, and virus replication increased, and patients actually did worse who received corticosteroids. One of the controversies in this disease is whether people should get NSAIDs, like ibuprofen or other such agents, or acetaminophen. As of now, acetaminophen is recommended by the WHO. This should say acetaminophen and not NSAIDs. Are recommended by the WHO. But this recommendation is not really based on anything, any evidence right now. So final thing is, what's the goal of all the interventions we're making? I think this has been discussed a lot, but the idea is if the curve in orange or brown is the normal epidemic, this is a way for everybody in the community to become infected. There'll be a large amount of herd immunity, 70 or 80% of patients, people might become immune, but the issue is you have a huge mortality. So if you delay the epidemic peak, the height may be less. Healthcare systems will be able to handle the infections much well. There'll be less herd immunity, but at least more people will survive, and healthcare facilities won't be overwhelmed. The concern is that if you then lift all your precautions and you flatten the curve, that you may end up something like the blue line here, where there may be a resurgence. I think there's an excellent chance that this virus will disappear in the spring this year, whether because of the heat or for other reasons, and then reappear in the fall or spring next year. Nobody, of course, knows this, but this is a major concern. We know that unless there's a lot of asymptomatic infection, we know that the majority of people will not have immunity to this infection. So another last thing that was raised was, well, how long does the virus persist on surfaces? And there was just recently a study, this is an older study, but this was recently a study in the New England Journal of Medicine that suggested virus could survive on surfaces for 2 to 3 days. This is true, and this is why people need to wash down various surfaces. However, what's not really clear is that, for example, if this chair up here, if somebody sneezed on it 3 days ago, and there's still a little bit of infectious virus, how easy would it be for that virus to then transmit to infect someone? Certainly if that person is washing their hands after touching all objects like this, the transmission won't occur. This is a bigger concern, surgical gloves, because not necessarily that it'll survive for 8 hours, but because it's really important that healthcare workers take off their gloves properly so that they don't end up self-contaminating. So just some final false information, or not false, some of it's false and some of it's more facts. So anti-HIV and anti-flu antivirals work against the coronavirus. One anti-HIV drug that was used was Kaletra, and we know that that doesn't work against it. There's just a big study in the New England Journal, though it's still being studied by the WHO. Anti-flu antivirals, the ones against the neuraminidase don't work because there is no neuraminidase on coronaviruses, but maybe there's some information that one of the anti-polymerase genes, anti-polymerase drugs could work, but this is really not proven. The virus is mutating, that's why it is spreading. Virus could mutate, but that is not why it is spreading. It's spreading because it infects both the upper airway and the lungs. And so far, there's actually very little evidence that it's mutating in a substantial way. I know there's studies coming out saying this may be questionable, but right now, that's what we think. The virus is man-made and engineered. This is certainly not true, though it's part of the popular press in certain places. It was neither made in Wuhan nor made in the US and then released. The virus has too many characteristics of a bat coronavirus for that to be close to being true. Then how to get into humans, we already addressed this, how it's really a bat virus and probably went to be an intermediary host. The virus will go away when the weather warms up. This may occur, but we also worry that it'll come back again. And we don't even know that it will go away. Different viruses have different tempos around the year. RSV and flu have different patterns of infection at different times, and we don't understand why. And the virus will become a seasonal respiratory virus like rhino or endemic coronaviruses. This is certainly a possibility, particularly if it becomes attenuated a bit. And with that, I will stop.
Thank you, Dr. Perlman. Wonderful content and slides and very pertinent. Seems like you addressed a lot of important questions that everyone's having today around transmission and how to stop the spread of the disease. We do have quite a few members here in the audience. We've gotten some questions from them from before the lecture, so but others feel free to add questions in the chat as we're talking, and we will be sure to address them. One of the questions that was raised prior to the talk was around wearing masks in public. I know in some cohorts overseas, it's quite common and not so much in the United States. Do you have comments around that now that it's widespread human-to-human transmission? Yeah,
so I think there's different thoughts about masks. So for a long part of this epidemic, people are saying masks don't really help. But they don't really help if you're not infected and you go out in public and you're wearing a mask. It's not going to protect you, particularly from getting infected. Masks are porous. People take them off improperly. The one thing they did do is they prevented you from touching your face, which may be good because that's how the virus is spread. More recent, this concept has been slightly changed more recently because with the notion that asymptomatic people could actually spread the virus by just even something as simple as talking. It may mean that a virus wearing a mask may have a little more efficacy, but it's still really not proven. And when you weigh that against the fact that there's such a huge deficiency in masks in healthcare centers, this probably is worth still supporting the notion that people should not wear masks. Now, if somebody is sick with this and needs to go out or needs to go around their family, then they should wear a mask. But for the general public, even though we see people all throughout Asia wearing masks, we don't think it's helpful.
Okay, and what about healthcare workers as there's different guidelines, obviously, from different health systems, some recommending everyone to be wearing masks at all times, even if they're not taking care of suspected patients. Do you have comments around that?
Yeah, so that seems almost contradictory to the notion that people shouldn't wear masks. But in fact, healthcare workers are such higher risk. I think that healthcare workers wear surgical masks in general, particularly if they're around someone who has an infection. But if there's someone who has COVID-19, then they wear what's called an N95 mask, which has a smaller pore size and is much more protective against the disease. The same rules apply with this, though. You can't be cavalier if you're wearing an N95 or a surgical. You still have to take it off carefully, have to take off your gloves carefully, wash your hands. So it's more protective, but people in healthcare facilities, just because we know that there's such high risk for becoming infected, that's why they wear masks.
Right. I think you bring up a good point. The donning on and off is key as not to touch the outer surface of the mask as we're taking it off, and washing hands again. Is that right? Now, there was a question that was raised around the possibility of transmission or aerosolization when a healthcare worker is doing a nasopharyngeal swab. And do we think that is enough that they would need an N95 versus a surgical mask, considering how short we are in general with PPE?
Yeah, I don't know the answer to that, because I can imagine if somebody actually had a high virus load, I'd want to wear an N95. This one, I don't know what the official recommendation is, whether to wear a surgical or an N95. I know when people are in drive-in centers where specimens are being obtained, they're certainly wearing gowns and gloves, but I don't know what kind of mask they're wearing. I would personally want to wear an N95, but I don't know what the official recommendation is.
Right. Okay. As the temperatures get warmer, across most of the countries, do you suspect that's going to change things in terms of the spread of the virus?
Yeah, this is a good question, which I think a lot of people are thinking about. Yeah, so in the past, as I was saying before, there are these distributions of infections. So flu seems to be one time a year, RSV is a little different. These viruses are all very similar. So there's something about the seasonality that we don't understand. We know in the tropics that these viruses are often year round. So the viruses there don't seem to mind hot, humid weather. But it seems like in the temperate zones, like most of the US and much of the world, viruses do disappear over the summer. So what this one will do, we hope that it'll disappear over the summer, and there's some chance, but I don't think it's predictable. It's predictable based on other viruses that they will disappear, but it's not obvious. We know that viruses like flu, which have really been well studied, really like dry, low humidity and lower temperatures. So, but again, the viruses seem to do fine in the tropics.
Okay. Well, we've got some questions in the chat here. There's questions around treatment. I see. Is there any data on remdesivir from China or Italy?
I mean, I don't think I know that. Yeah, assuming it's made properly, which I think it should be, it should work fine. Of course, I don't know the local manufacturing processes in China and Italy and how carefully it's done, but I would assume that these can be constructed. These can be done properly, but I don't know specifically if they're bad or not, or how well they work. I would guess fine, but I don't know.
And a follow-up there, what about, it says efficacy of favipiravir for COVID-19?
Yeah, that's a question. That's the flu polymerase drug. And it's been studied in a non-controlled way in small populations, and it seems to have some efficacy. But like so many drugs in this disease, when you give a drug to somebody and they get better and you don't have a control, you don't know why they got better. And so this is a problem with a lot of the drugs that are being used for this infection. Given to some patients, patients get better, but whether it has anything to do with the drug is not clear.
Okay. A bunch of questions, as expected, on regarding hydroxychloroquine and azithromycin. I know it's been
It's exactly the same answer as the last one. Here, this is even more problematic because I think that this has been mostly tested by a limited number of research groups and completely non-controlled studies, and patients get the drug and then walk out, and it's not really clear how sick they were to begin with. Certainly no controls to know that the drugs had any effect whatsoever. Azithromycin having an effect is not really clear why it should have an effect. And hydroxychloroquine has a theoretical basis for inhibiting the virus, but in fact, viruses don't enter cells by the pathway that's inhibited by hydroxychloroquine unless the primary pathway of entry doesn't work. So in theory, one agent, I don't know why it would work, and the other one has issues as to whether it would ever work in this disease.
In the setting of sort of not having sort of a definitive antiviral treatment or having access to remdesivir, I suppose it's it's fair to that people I know have been using hydroxychloroquine in many countries and even in the United States.
Yeah, I know, but as physicians, we always want to do something for our patients, but hydroxychloroquine has side effects that could mean that you're not necessarily always doing either something beneficial or neutral. It could be negative as well.
Right.
And so I think it's really needs study, and there's just little evidence so far that it's working really. So I know people using, my hospital does as well, but it doesn't mean that it's right.
Okay, thank you. I have a question which just says role of interleukin-6. I do not sure what the...
Yeah, I think this is, I know what the question is. I think this is an interesting question because this comes under the notion that can you reach a situation where you inhibit the virus with a drug like remdesivir or something else, and then you come back with anti-IL-6 antibody to tone down the immune response. IL-6 is elevated in this disease. Whether this will work like that, we don't know. We need a trial to test that. But I think that's an idea that people will pursue more as we have a better understanding of how much the disease is actually caused by the host immune response. So agents like anti-IL-6 antibody or other such reagents may be useful.
Okay. Now, I know you touched a little bit on immunity sort of generated by previous sort of MERS and SARS-CoV-1 as well. There's sort of a similar question around SARS-CoV-2. Can the infections recur in the same individual? How long do we expect the immunity to last?
Yeah, this is a $64,000 question because we think, I would bet that a reinfection occurs sometime, but I don't know if it's going to be after immunity wanes for a year, 5 years. Because the other thing about even the studies we did where immunity goes greatly decreases, we don't know that people don't have memory B cells that can activate much more quickly. One of the goals is, in this case, if people all develop colds now instead of serious lung disease, it would be much less of an issue. So even if you had immunity, you didn't prevent reinfection, but you prevented clinical disease, that would be just fine.
Okay, thank you. And question that has come up in other places as well, the use of ACE inhibitors, posing a risk for those infected with COVID-19. Your thoughts on that?
Yeah, so I think that there's a theoretical risk that this is a possibility, but this is very complicated because what we think ACE inhibitors do will increase ACE2 levels. So on one side, maybe you have more virus receptor, so maybe the infection will be more abundant. But on the other hand, ACE2 is considered antiviral and anti-inflammatory. So having more of it may be useful. Right now, the bottom line is we don't really know how this will shake out, and people should not stop their antihypertensive medicines because that's a bigger risk than these more theoretical risks on what the medicines will do. There'll be studies coming out. Hypertension is considered one of the risk factors for this, but we don't know how many of those people are on drugs when those kinds of studies are done. And in fact, in China, I think only a minority are on drugs. So we still need more information. Okay.
The last few minutes, we still have a few questions on transmission prevention. We have Brent, physical therapist, he says, as physical therapist in an outpatient setting, typically we have a lot of contact with patients. To what degree should we limit our physical contact with patients, and how much PPE should we be using? Especially, I suppose, if we're worried about those who are asymptomatic, obviously, I would assume we're talking about then not symptomatic patients.
Yeah, this is really, I don't know how to answer this question. If I would think that I would probably do, and this is not based on anything scientific, if the patient didn't need physical therapy on a weekly basis, I'd probably put it off until some of this is passed. If they do need it, then I would probably, this is a situation where I'd probably wear a mask and certainly wash my hands continuously. But that's the best precautions. And we're make believe or assume that they could be infected without going, or, if they're completely asymptomatic, probably washing hands is all you really need, being very careful about that.
Right. I think there's another question from Bethany around sort of similar areas. How much asymptomatic or pre-symptomatic transmission do we feel is actually occurring in the community and in the hospitals? I know there's different, she quotes different numbers from CDC versus the WHO China study, the CDC numbers being as high as 12%. So.
Yeah, I think that the issue is, this is something I tried to allude to. We don't know if these patients are prodromal, they're just starting, or if they're really asymptomatic. Any way you look at it, it just means that everybody in the community could potentially be a transmitter. If they're completely asymptomatic, then, as I said, you probably have to do something like get it through talking. So social distancing and washing your hands should really minimize those possibilities. That's why it's hard for that physical therapist to take care of his or herself, because you really can't do that except for washing your hands.
Right, right. And likewise, we're going to the grocery store, or, doing our essentials, so going to the pharmacy, coming back home, should we be washing our clothes or changing our clothes every time?
You should be washing your hands every time.
Yeah.
Clothes, if you work in a hospital, then, as particularly if you're around COVID-19 patients, then you should come home and wash your clothes. I don't know how much transmission would come from clothes, but I don't think you want to find out. So I would do it then. But just walking into a store, I don't think you're going to get infected walking next to someone who's walking their dog. You're walking your dog, or you're in a grocery store. Obviously, if they were to sneeze on you, the first thing you should do is run over to the sink and wash your hands. That's the most important thing.
And last one we have, well, there's a question around asymptomatic testing. Do you have recommendations for that?
Yeah, it's a hard one, because I think we'll pick up a lot of positives. We'll learn much more about what the denominator is and the number infected. On the other hand, it's not like we have lots of testing kits yet. We're still a little short of them. It's not inexpensive to test everybody. So this is more a policy decision. Certainly it'd be great if everybody could be tested. The other thing is that how often would you test them? Because someone could be negative today and positive in 2 days. So maybe confining it to contacts in older people.
Mm-hmm. Okay. One final one as we finish, the question around why has China been so successful in controlling the virus? Well, it's probably a lot of things, but any
well, I think that they did a really very stringent suppression. So everybody stayed in their homes. I know my friends in China often had their food delivery person come for 50 households, put it in a central area. People came individually to pick up the food, maybe wipe down the food packages, which probably wasn't necessary. But if you completely immobilize your population, you're going to have a better chance of containing it. And that's all well and good, but it has such huge economic and social costs that that I don't think most countries would want to do that.
Okay, well, thank you once again for taking our time during this time. I know this is sort of a crisis mode with lots of uncertainty everywhere, so we really appreciate you coming out and sort of giving us all the information today. We've had visitors, our collaborators from Cameroon, being a Baptist hospital there, their internal medicine residents who joined us today. We have radiology residents from University of Rwanda who have joined, and our collaborating friends from Bhutan and India as well. And we have Pam and other friends from Bhutan as well. So thank you to everyone. Thank you to Dr. Perlman for joining us today. Stay safe, be well. We will get through this as we stay informed and take care of ourselves and our friends and family and community. Just on a final note, we do have another lecture from Health for the World coming up this Friday from Dr. Peter Chin Hong from UCSF, who's an infectious disease specialist and is in the front lines of taking care of patients here in San Francisco. So this is April 3rd, this Friday, same time, same meeting ID. We will see you all then. Be safe. Thank you.